Hi, it's Andy Brokenbrough. Thank you for attending this month's Kent Northwest Kidney Center in service. Um, Also, thank you for your wonderful care of our patients, particularly during the recent snowstorm. It was noticed and is much appreciated. So, today we're going to talk about anemia, or a low red blood cell count, and why it is such a big problem among dialysis patients. Managing anemia, it's a really important job of dialysis units, and so it's important for anyone who works in the dialysis field to be familiar with anemia and its treatment. Anemia, as you all probably know, is extremely common among hemodialysis patients and is responsible for some of the symptoms associated with kidney disease, such as fatigue, low activity levels, shortness of breath, among others. And anemia is also associated with some really bad heart problems. So there are four objectives for today. First, we'll define anemia. Second, we'll review causes of anemia among dialysis patients. Third, it's important to be familiar with the management of anemia. And finally, recognize potential side effects of erythropoietin. Let's begin. So anemia. Anemia is a reduction, defined as a reduction in hemoglobin, or a reduction in the number of circulating red blood cells. For people with normal kidney function, the World Health Organization defines anemia as a hemoglobin less than 13 grams per deciliter for men and less than 12 for premenopausal women. Anemia is not specifically defined for the dialysis population, although the generally accepted goal for dialysis patients is to keep the hemoglobin above 10. Anemia was first linked to kidney disease over 170 years ago by Richard Bright. Richard Bright was an English physician who did research into the cause and symptoms of kidney disease. He's known as the father of nephrology. And some of you may have heard the term Bright's disease. We don't use it anymore, but it describes what modern medicine calls acute or chronic nephritis, generally characterized by swelling, the presence of albumin in the urine, and it's frequently accompanied by high blood pressure and heart disease. So it's an old term, but a nod to his contribution to the field. Nearly all patients who are on dialysis are anemic. There are many complications of anemia and end-stage renal disease. The ones we know about for sure include fatigue, shortness of breath, the need for blood transfusions. Other complications include likely reduced quality of life. Anemia is accompanied by fatigue, which can really limit activity. Possible complications include increased cardiac events, heart attacks, thickening of the heart muscle. We call that left ventricular hypertrophy. Okay, let's first talk about the causes of anemia in dialysis patients, and there are many. So for starters, dialysis patients can lose blood. It's a very common problem. Second of all, dialysis patients oftentimes have nutritional deficiencies such as iron and folate and B12. Chronic inflammation, which is highly prevalent in dialysis patients, also can contribute to anemia. And finally, the most important of all is something called erythropoietin deficiency. We'll talk about this in detail, but essentially the kidneys make a hormone called erythropoietin, which stimulates red blood cell production in the bone marrow. In most dialysis patients, the underproduction of erythropoietin is the main reason for anemia. Okay, first let's talk about blood loss. Dialysis patients lose blood with the dialysis procedure. For example, some blood remains in the filter and in the tubing, the so-called dialysis circuit, at the end of the procedure. Dialysis patients undergo frequent blood draws. They can also lose blood from their fistula, especially after the needles are withdrawn or before clotting occurs. Gastrointestinal bleeding is also very common. Dialysis patients receive heparin with the dialysis procedure, and many dialysis patients use other blood thinners or anticoagulants such as aspirin or warfarin. This is one of the main reasons why dialysis patients often lose blood through their gastrointestinal tract. In fact, GI bleeding is 100 times more common in dialysis patients than in the general population. Premenopausal women often lose blood every month with menstruation, and this contributes to anemia as well as iron deficiency. Okay, nutritional deficiency, a very common problem among dialysis patients. Dialysis patients are always making new red blood cells, and this process consumes a lot of nutrients, such as iron and folic acid and B12. The most important of these is iron. Iron deficiency is very common among dialysis patients because so much iron is used in the process of making red blood cells. And dialysis patients make a lot more red blood cells than the general population because red blood cells have a shortened lifespan among dialysis patients. As an aside, it's very important to administer iron intravenously during the dialysis procedure rather than orally. Here is a study which basically showed that oral iron was no better than placebo in supplementing iron in dialysis patients. In other words, the absorption of oral iron is so poor in dialysis patients that you might as well not give it at all. Folic acid and B12, these are B vitamins, water-soluble vitamins which are lost during the dialysis procedure, but are essential for red blood cell production. This is one of the reasons why we prescribe renal vitamins to our patients. So if patients don't take a renal vitamin or have a poor diet, then they can become deficient in folic acid and B12, and this can impair red blood cell production on the basis of nutritional deficiency. Okay, inflammatory block is a big cause of anemia in dialysis patients. So what is it? Well, inflammation can be caused by basically any illness, including end-stage renal disease and all the health problems that our dialysis patients have. And illness, for whatever reason, is a stress on the body. This revs up the body's immune system in a process called inflammation. And inflammation negatively impacts the body's ability to make red blood cells. Inflammation is probably responsible for about 20% of all the anemia in dialysis patients. So in other words, kidney failure and the dialysis procedure are associated with a chronic state of inflammation, and the body does not make red blood cells well in the setting. Why does this happen? Well, for starters, uremia is thought to occur as a result of accumulation of waste products in the blood, and there are probably some uremic inhibitors of red blood cell production. One of these is called a protein, an inflammatory protein called hepsidine. So we're going to talk about that. Hepsidine was discovered in 2000. It's a protein in humans. It is synthesized by the liver. Interestingly, it's a key regulator of the entry of iron into the circulation or the bloodstream in mammals. So basically, there are significant iron stores inside of cells, but the iron needs to be able to leave these cells and go into the bloodstream, where it will then travel to the bone marrow, where it can be used as a building block to make red blood cells. Hepsidine reduces the extracellular iron, that is the iron outside of cells available for red blood cell production in the body by several mechanisms. And this is a bad thing if you're trying to make more red blood cells. So how does hepsidine keep iron out of the bloodstream? Well, there are several mechanisms. For starters, hepsidine decreases the absorption of iron in the intestines, and this is one of the reasons why oral iron is not well absorbed in dialysis patients. Second, the liver has lots of iron stored inside of its cells, and hepsidine reduces the ability of iron to leave the liver and go into the bloodstream. There are also cells in your body called macrophages, which contain a lot of iron, and hepcidin prevents iron from leaving these cells as well. So both the liver and macrophages, which are a type of white blood cell, are part of something called the reticuloendothelial system and are significant storage areas of iron in our body. Okay, so how does hepcidin do this? How does it prevent iron from going into circulation? Well, when the body is inflamed, the liver responds by making more of these inflammatory proteins, including hepcidin. It turns out that hepcidin binds to a channel inside of the cell membrane of cells like the liver and the macrophages. And this is a channel by which iron leaves the liver cells and macrophages. But when hepcidin binds to that channel, both the hepcidin and the channel are taken up inside the cells, and you lose the channels that allow iron to leave the cells. Okay, so why in the world am I talking to you about hepcidin? Well, for starters, hepcidin inhibitors are currently being studied as a possible treatment for anemia in dialysis patients. And also, a fun fact, there is this genetic condition called hereditary hemochromocitosis. The prevalence is about 1 in 150 people of Northern European descent, and about a little over 1 in 10 people of European descent is a carrier for the gene. You need 2 copies of the gene to have disease. But in this condition, the liver does not make enough hepcidin. So hepcidin production by the liver is low. And this leads to the opposite situation where you have too much absorption of iron by the intestines, too much iron being available into the circulation, which travels to other organs and deposits in the tissue, such as the heart, pancreas, liver, and the brain, resulting in a state of iron overload. Okay, so now the last and most important cause of anemia in dialysis patients is due to a deficiency in a hormone called erythropoietin. Okay, so erythropoietin is a hormone produced by the kidney, which stimulates red blood cell production in the bone marrow. Erythropoietin levels in dialysis patients are typically only 1 to 10% of values found in people with normal renal function. And erythropoietin deficiency is responsible for about 80% of anemia in the dialysis population. Again, about 20% of anemia in dialysis patients is, quote, resistant, end quote, to epogen for various reasons, and inflammation is probably the main factor. Okay, so there's a history to erythropoietin. In 1904, Paul Carnot, he's a professor of medicine in Paris, first proposed the idea that there must be a hormone in the bloodstream that regulates the production of red blood cells. And the way he proved this was by bleeding rabbits. So essentially he took a group of rabbits, he bled them down to the point that they were very anemic, and then he took blood from the anemic rabbits and infused it into another group of rabbits. And the second group of rabbits then developed really high red blood cells in their blood. In other words, the anemic rabbits underwent a procedure of essentially transferring their blood, something in their blood that stimulated the normal rabbits to make more red blood cells than usual. So that's how we first figure out that there must be a circulating factor that stimulates red blood cell production. But it wasn't until 1977 when a researcher named Miyake was able to isolate erythropoietin from 2,500 liters of urine from patients with a severe form of anemia called aplastic anemia. And this allowed for the subsequent identification of the gene that encodes for erythropoietin and then the production of this compound commercially. In 1980, 1987, Joe Eschbach, a nephrologist who worked at the Northwest Kidney Center, conducted the first clinical trial of Epogen. And I think it's just amazing that the first Epogen trials were conducted at our organization. In 1989, Epogen received FDA approval. Okay, so this is a picture of Joe Eschbach. He published a couple of landmark papers using erythropoietin. First, in 1987, he did a study of 25 Northwest Kidney Center patients who were given erythropoietin and reported that no further transfusions were needed. And this was a huge breakthrough because most dialysis patients up to this point were transfusion dependent or needed to be transfused blood on a regular basis during dialysis. He also published a phase 3 trial of 333 hemodialysis patients with hematocrits less than 30% who were given Epogen. Their mean hematocrit increased from 22 to 35%. And basically the transfusion rate decreased from over 1,000 in the previous 6 months to virtually none. So this basically, the introduction of recombinant erythropoietin basically replaced the need for blood transfusions in dialysis patients. Okay, so why is it such a great thing to avoid blood transfusions? Well, for starters, there's always a risk of infection, particularly hepatitis B and other bloodborne viral infections through a blood transfusion. Second of all, if you transfuse a dialysis patient, they may develop antibodies to common proteins in the blood, which may make it harder to find an immunologically matched kidney transplant. This is called sensitization, and if your dialysis patient becomes sensitized to common proteins, then it becomes very difficult to find them kidney transplant. And finally, prior to the introduction of erythropoietin, many dialysis patients developed what was called iron overload syndrome. So blood transfusions contain a lot of iron, and if you receive a lot of blood transfusions, your bloodstream level, iron level can rise significantly, and then this can deposit in major organs such as the liver, the pancreas, the heart, the pituitary, and this produces the same clinical picture as the genetic condition we discussed a little bit ago called hemochromatosis. Okay, so back to erythropoietin. Erythropoietin is a circulating hormone that has many effects beyond just raising red blood cell production. These include wound healing, the brain's response to neuronal injury, vasoconstriction or tightening of the blood vessels. Erythropoietin can stimulate the growth of blood vessels. We call that angiogenesis. It can stimulate the proliferation of smooth muscle fibers. Increases intestinal iron absorption, probably improves memories. There are several studies that have demonstrated an increase in activity in a part of the brain called the hippocampus, which affects memory. And it also may have effects on mood. Okay, erythropoietin blood levels. So basically they're very low in the absence of anemia, but they can increase 1,000-fold or even 10,000-fold under hypoxic stress. So if you don't have enough oxygen in your blood, your body will make a lot more erythropoietin. This is why patients with lung disease often have very high hemoglobin levels. Now there's one exception. Erythropoietin blood levels tend to be very low in patients with polycystic kidney disease and patients with renal tumors. And these patients oftentimes have relatively robust hemoglobins on dialysis and don't need erythropoietin. Okay, so recombinant erythropoietin, or epoetin alpha. In at least 2010, it was the single greatest drug expenditure by Medicare. I don't know if that's the case anymore. I couldn't find that information when I tried to look for it. But suffice it to say that CMS knows that it spends a lot of money on this drug. Okay, so now let's shift gears and talk about the management of anemia. So we screen all patients for anemia upon initiation of dialysis with a CBC, or a complete blood count. Hemoglobin is then monitored at least monthly. Of course, we'll check it more often if it's clinically indicated, like the patient just underwent a surgical procedure, or they just got out of the hospital, or they've had some bleeding. In general, we don't start erythropoietin until the hemoglobin is below 10. And we shoot for a target range of 10 to 11 based on consensus opinion, although the optimal target hemoglobin for erythropoietin dosing is not exactly known. Okay, so how do we treat anemia in dialysis patients? So, of course, we give them recombinant human erythropoietin. We also give them intravenous iron. Um, we'll talk about IV iron in a separate talk in greater detail, but in general, it's important to keep to administer intravenous iron either before or along with the epogen. Indications for intravenous iron include a transferrin saturation of below 20% or a ferritin of less than 200. Okay, so the goals of therapy, reduce the need for transfusion and improve quality of life symptoms, exercise tolerance, and the need for transfusions. Okay, there are several different erythropoietin stimulating agents or erythropoiesis stimulating agents, we call them ESAs, available in the market today. So we talked about erythropoietin alpha or epoietin alpha. There's epoietin beta and epoietin theta. Epoietin alpha is manufactured by Amgen, and of course it's approved by the U.S. Food and Drug Administration for use in dialysis patients. We also have these medicines called biosimilars. A biosimilar is a biologic product that is highly similar to and has no clinically meaningful differences in effect from an existing FDA-approved reference product. Biosimilars for erythropoietin or for EPO alpha were approved by the FDA in 2018 for the treatment of anemia. And the approved dose is the same it is for epoietin alpha, and the physiologic effect is the same. We also have longer acting erythropoiesis stimulating agents. One of them is darbepoetin. We actually used to use that one at the kidney center here. It's another form of recombinant human erythropoietin. Basically, there's a fairly large oligosaccharide chain that is linked to its N-terminus, and this extends its half-life, increases its biologic activity, and it's been used for 20 years now in the treatment of anemia and chronic kidney disease. You can give it IV or subcutaneous. Similarly, there's one called Methoxy polyethylene glycol epoietin beta. We just call it Mircera for short. This is a long-acting erythropoiesis stimulating agent, kind of like Aranesp. It was approved by the FDA in 2007, and it became available in the United States in 2015. And it's made by essentially linking erythropoietin beta with a large molecule called methoxy polyethylene glycol butanoic acid. This decreases the affinity of the erythropoietin receptor, but it has a much longer half-life, and we've used it at the kidney center since 2018. Okay, so this slide shows the differences in half-life for some of the different agents. So basically the half-life for EPO alpha is about 7 hours, for Aranesp about 25 hours, and for Mircera is about 130 hours. So basically you can increase the half-life of EPO alpha with this side chain so that it's 20 times greater. So it lasts for several days in the plasma, which is why it can be dosed every 2 to 4 weeks. Okay, fun fact, July 17, 2008, the Italian bicycle rider Riccardo Rico was disqualified from the Tour de France because the urine sample tested positive for Mircera. So, unfortunately, these medications have been abused by athletes who want to increase their ability to deliver oxygen to their tissues by making more red blood cells. Okay, so now we're going to talk about target hemoglobin levels. Okay, so although erythropoiesis-stimulating agents have been shown to provide benefit compared to not using them. The optimal target hemoglobin for dialysis patients is really not well defined. In most dialysis patients, we try to maintain it between 10 and 11, but there used to be interest in normalizing the hemoglobin. So basically, for the first 20 years of ESA history, we thought, well, maybe if a little bit of erythropoietin is good, maybe a lot would be better. But unfortunately, there were multiple studies showing that if you try to normalize their hemoglobin, that is, increase their hemoglobin to 13 or above, that unfortunately there is an increased risk of complications, death, non-fatal heart attacks, higher mortality, greater risk of access thrombosis, greater risk of hospitalization. Probably the best of these studies which demonstrated is by Besser, published in 1998, basically looked at 1,200 dialysis patients with cardiac disease, so heart failure, heart attacks, who had baseline hemoglobins between 9 and 11 on Epogen, and they basically randomly assigned them to achieve and maintain a hemoglobin of either 14 or 10. What they found, the study was terminated early after 29 months because there were more adverse events in the high hemoglobin. So there was a higher risk of death and non-fatal heart attacks, 7% higher 1 and 2 year mortality rates. There was a greater risk of access thrombosis, 39 versus 29%, and there was a greater risk of hospitalization. Okay, so in addition to these data, which were limited to hemodialysis patients, a number of other randomized controlled trials have been performed, mostly including non-dialysis CKD patients, and most suggest that targeting higher hemoglobins with ESAs does not lower mortality and actually increases cardiovascular risk as well as the risk of malignancy. So, for example, Parfrey looked at nearly 600 dialysis patients. There was an increased stroke risk if you normalize hemoglobin. Drucadol, 600 CKD patients trend towards increased mortality with higher hemoglobin. Singh, CKD, no benefit to higher hemoglobin with increased cardiovascular risk. And finally, Pfeffer looked at a study in the CKD, the non-dialysis population. There was no clear benefit to a higher hemoglobin, and there was an increased risk of stroke and cancer deaths. Okay, so why are the adverse side effects? Well, it's probably because that it's likely anyway that supraphysiologic doses of erythropoiesis-stimulating agents, especially in very high doses or in patients resistant to treatment, have effects on other tissues. So again, there are receptors for Epogen on the heart and blood vessels and the brain, etc. But you know, we know that giving anything in massive supraphysiologic doses has the potential towards untoward effects, and that's why there's been a renewed interest in finding alternatives to Epogen. More of that to come in the future. Okay, so our current understanding, targeting hemoglobin above 13 is harmful. A hemoglobin of less than 10 is probably associated with diminished quality of life just because of shortness of breath and fatigue. So in general, we try to keep the hemoglobin between 9.5 and 11.5, likely to be both beneficial as well as safe for our dialysis patients. Okay, so in summary, anemia contributes to many of the symptoms associated with reduced kidney function. Partial correction of anemia provides some benefit. So we routinely monitor all dialysis patients for anemia and iron deficiency. We check their hemoglobin at least monthly, sometimes more often. We treat anemia with erythropoiesis-stimulating agents and/or intravenous iron. And again, the target hemoglobin, ideally between 10 and 11, we know that above 13 is associated with adverse outcomes. Okay, so now it is time for the quiz. Name 3 causes of anemia in dialysis patients. Okay. You got it. Erythropoietin deficiency, blood loss, nutritional deficiency, again, iron, folic acid, B12, and inflammatory block. Excellent. High levels of this molecule cause inflammatory block anemia. Okay, that's right, hepcidin. So hepcidin, again, is that inflammatory molecule which is synthesized in the liver. It's upregulated in settings of stress or inflammation, and the hepcidin binds to the channel that allows iron to leave cells. And so if it binds that channel, it gets taken up by the cell, both get destroyed. There's no channel by which iron can leave the storage cells. So basically you end up with very low levels of circulating iron in the blood. Okay, what are some advantages to treating anemia in the dialysis population? Okay, improved energy, better quality of life, and decreased need for transfusion. So again, whatever we can do to avoid transfusion is of critical importance for our dialysis patients, particularly if they are a candidate for a transplant. So why is it good to avoid transfusion in dialysis patients? Okay, avoid the risk of infection, avoid triggering antibody production to foreign proteins. Again, antibodies make transplant more challenging, and the risk of iron overload. Cost, of course, is another issue. Transfusions are very expensive. Okay, last question. What are some problems associated with raising the hemoglobin to 13? Okay, increased risk of cancer, increased risk of mortality, heart disease, hospitalization, access thrombosis, and blood clots. Okay, thank you all so much for listening. I hope you learned something, and we'll do this again another time. Take care.